8:30 now, so I think we'll get the conference going and we will have other people join us. But I want to welcome everyone to the worldwide conference for our ARCO 2020 workshop. And this has taken quite a bit of planning. I know some people are up late at night and some people are up very early in the morning. So I appreciate your sacrifice on behalf of trying to improve the care of our patients. It is, I admire your dedication and look forward to working with all of you and trying to, I appreciate the trust and the responsibility that you have let our organization take on. So we'll get started. Caitlin, let me ask you to advance to the next slide, please. Okay, so this is the current ARCO board. Just to remind you, I want to also thank the board members for their involvement in this process. It has been ongoing for many months, and I'll explain the background. As you see, for those of you who are not familiar with the leadership, there are numerous vice presidents in all of the geographic representations listed, I think all have been involved in making decisions and trying to promote various projects, research projects that we have that are ongoing. So the next slide, Caitlin. We have a number of our board members as well as other individuals online. I think Carol, the administrative assistant, will take attendance, but you can see the listings here. What PICO refers to, and I'll mention this in a few minutes, is the research question we will be addressing. And the groups have been assigned for various research questions. There are 3 of them, which I'll go into later. The first question is not as difficult. The second and third questions are more difficult. And so we've made those groups a little bit larger. In addition, there will be a lead person for each group as the first name. So for the first group, that would be myself. For the second group, that would be Trey. And the third group would be Stuart Goodman. I don't see his name online yet. Hopefully he's joined. Stuart probably had the earliest time when we were organizing this call. I know those in Asia are late at night, and those of us from Stuart is very early in the morning now.
Ed?
Yes.
I don't believe Stuart is going to make this call, but he is having someone, because he's actually still has his clinic schedule. He has asked Catherine Huang to step in for him at today's meeting. Okay,
excellent. And in addition, we know many people will not be able to join the call because of their work duties. And so this is being recorded. We will post this so all of you are able to view this later for either reference or viewing at a later time. It'll probably be posted on a YouTube format, which is, of course, widely available. So you can see the names there. Now, some of you on the call may not have been assigned to a research question group. If that's the case, and if you wish to join and participate in the work, then please let me know. Just send me an email, or well, it would be best to send it to me and we can assign you to a group. If you have a preference, then please let me know and we'll get you assigned so that you're involved in the communications with that particular group. So those are the names listed. They are also some organization with respect to geographical representation and expertise. All right, next slide there, Caitlin, please. I think the goals for today's meeting will be lasting for approximately 1.5 hours, and we're going to accomplish the following. We will review the background of where we are in this project and how we got here. We will review where we're going to go forward and what steps we will take. The research questions will be reviewed, and there'll be time to provide input for that. However, they are pretty much established at this time. We will also review the process for developing a clinical practice guideline. So that's what CPG refers to. That's the clinical practice guideline. And there is a specific iterative and process that one must go through that results in a higher quality clinical practice guideline as opposed to a number of expert opinions explaining their own treatment. And we will go through training for the first step of how we go about doing this evidence-based gathering. The purpose we hope for this call is to go through the training of that and determine also how we will do that training, both the techniques for doing it as well as the criteria for screening articles for appropriateness and inclusion and the subsequent analysis. This is probably the easier part of the clinical practice guideline process, but I think this will get our feet wet in terms of working together on this project. And then at the end, I think we'll have some time to review where we go from here in terms of the next steps. There will be a need for individual research committee groups to convene and probably speak on separate conference calls. We can assist with that process. All right, the next slide, Caitlin. All right, so how did we get here? And how did we formulate these research questions? Back in the fall after our last 2019 meeting in the springtime, that was well run by Dr. Zhao and his group. In Dalian, the board decided to pursue additional research projects. There were several ideas that were proposed in the fall that the board did vote on. One of the ideas was Professor Zhao's initial idea to propose a clinical practice guideline, although initially he had a draft, and I had suggested we could do this maybe in a more proscribed iterative format that might be more widely accepted. And so I suggested that maybe the entire ARCO society try and take this on. We are a small society, but we can try and work together. So the majority of the board did vote to pursue the development of a clinical practice guideline. So most of you know many countries have guidelines to help establish the management and treatment of particular diseases. This is not an uncommon practice, and has not really been done for osteonecrosis that we can see. So there was a need for this. So at that time, in the fall, I engaged the individuals at the American Academy of Orthopedic Surgery to seek their guidance, because the AAOS has performed and published quite a few clinical practice guidelines already on different musculoskeletal conditions. I spoke with Dr. Bob Quinn, who was the head of the Clinical Practice Guideline Committee, as well as the department involved in the AAOS. Jason Murray was the director, and several staff members whose names are listed there, Caitlin and Mary. And they provided input on the process that the AAOS follows and has developed, as well as the timeline and their experience in having orthopedic surgeons develop clinical practice guidelines. It became quite apparent to me at that time that we would not be able to do this alone. We did not have the resources or the expertise, I felt. Additionally, we had logistical problems in trying to work together as an international group. We did also consult with other experts in this area. Deborah Cummins was one who formerly was with the AAOS and is now with the Orthopedic Research and Education Foundation. She provided input. And I also spoke locally with our expert at the University of Minnesota who was on the call, and that's Caitlin Backer, who has quite a bit of experience. I will introduce her in a few minutes. However, she is here locally at the University of Minnesota and has performed work with various academies, including the American Academy of Neurology and the Cochrane Group, and has published, helped publish systematic reviews in various orthopedic and non-orthopedic journals. We were planning on having our workshop at the Orlando AAOS meeting, as you all know. And so we had to organize and arrange for this meeting. We had a venue set up. It was run quite well, I think. It was close by to the convention center and was reasonably priced. However, with the virus epidemic or pandemic, of course, all of our plans have changed, and we've been able to pivot to an online workshop format of an abbreviated time, only an hour and a half. It was not really too difficult to do this, as we've been practicing our conference calls already at our particular institution. So then in the wintertime, the board reviewed research questions, and these were proposed, and feedback was requested on the different research questions that might be undertaken with the clinical practice guidelines, and I'll review them in just a second. After the research questions were approved, and there are quite a few of them that are condensed into 3 major topics, the literature review was undertaken, and I worked with Caitlin to perform the literature review and refine this to reach the point where we felt that and were comfortable that we had captured the world's evidence on this condition, osteonecrosis of the femoral head, yet it was not so large that it was unwieldy. Nonetheless, it is quite large with numerous articles that will need to be reviewed and screened. Most of the articles will probably not be appropriate for inclusion, and we expect that, but that's the way we ensure that we have not missed any evidence that might be pertinent to the topic. So that's as I said, the goal, the first step in the first phase in the CPG development process is to review the literature. It is very time consuming and takes a fair amount of work. We'll review the tools for helping us accomplish that in just a minute. And then in February and March, of course, we had to plan for the workshop and move to the online format. Okay, the next slide then. What is a PICO question? PICO stands for the patient or population being studied, the intervention, or the treatment that's being assessed, and then a comparator where one looks at how the group performs relative to a control or a background or historical control, and then the outcome, what is the metric you're looking at. So this works best for treatments, but it can be applied to diagnostic tests as well. PICO is the acronym that's used to plan a research question that's well-defined and searchable, in which you can use for either systematic review or a clinical practice guideline. So at this phase, the process of doing a clinical practice guideline is very similar to a systematic review, and we've all read numerous of those that have been published. So 3 PICO questions or topics were agreed upon after surveying the board last fall, and I'll go into them now. The first question is in patients undergoing the diagnostic evaluation for osteonecrosis. What imaging studies, give them X-rays, MRI, CT, or other, for example, bone scan, what are the most sensitive and specific for either the diagnosis or detecting a subchondral fracture or monitoring the effect of any intervention or treatment or surgery? And which imaging tests might correlate best with symptomatic versus asymptomatic disease? Are there any tests that can still be determined which patients have symptomatic disease? As patients, we all have seen patients and wondered whether or not their symptoms are actually due to osteonecrosis or some other problem. So that's the first question. The next question deals with the early stage osteonecrosis, that is those patients who do not have a femoral head fracture or collapse. So in these patients who have no fracture or collapse of the femoral head, what treatment, be it surgery, such as cord decompression or grafting of some type, or cellular therapy, or it perhaps might be non-surgical therapy with bisphosphonates. But what treatment is best at preventing a subsequent femoral head subchondral fracture? We all are very interested in this question, and so it would be useful if we could condense the evidence in the literature into a recommendation or a guideline. For asymptomatic patients, what treatment, or does treatment, as opposed to just observing the patient, reduce the risk of a fracture? In other words, is there a treatment that's effective and should be employed at this stage? We know that several people on the call have written on this topic already. And then for symptomatic patients, should total hip arthroplasty be performed to reduce pain? At what point do you pursue surgical treatment with hip arthroplasty? I think around the world, we have different thresholds for performing this surgery. The third question deals with more advanced disease. So patients who have a femoral head fracture, whether or not there's collapse, that is, there's a subchondral fracture, what surgical treatment is the best for the patient? And we divided this into patients who are younger and patients who are older, since we might view them differently. And just based empirically, this has been divided into a 25-year time frame. So the older patient, perhaps, let's say above 60 or 65 and above, somewhere in that range, might be considered the older patient. And someone who has a greater than 25-year time span or lifespan expected would probably be considered a younger type patient. And at what point do we consider arthroplasty versus other hip preserving treatments, or should we ever perform them? I think is one question many people will have. And there will be some disagreement among us, I'm sure. All right, so at this point, we're going to be pursuing the clinical practice guideline process, and I have asked Caitlin, who, as you see there, is an expert and has worked with several organizations on this process and published papers on it, to work with us. She was supposed to be with us in Orlando. Many of you will, I'm sure, have the opportunity to meet her in the future. She's very knowledgeable about this, and I've heard her speak on this, and I engaged and asked her to help consult with us and guide us on this process and enable or facilitate what we can do as a small society. So I'm grateful that Caitlin has joined us. I've worked with her and had many meetings with her this past few months, and she's going to take over the lectern here and speak to you about the process and what we hope to accomplish going forward. So Caitlin, welcome.
Thanks very much, and thank you everyone for joining us today. I hope you're all able to hear me. If not, somebody please let me know. As Dr. Chang mentioned, I'm going to be outlining the clinical practice guideline development process. And so this process we approach in 5 phases. So we begin by developing the questions, and usually with a clinical practice guideline, there will be multiple questions that we are trying to address. We then proceed to gather the evidence that would address those questions. Once we have that evidence, we assess its methodological quality. We see whether the studies are robust, whether they are free of bias. And then we take that evidence that we've gathered and that we've assessed, and then we bring those pieces together. So we synthesize that information and develop recommendations to address those questions. So today, really what I'm going to be focusing on are the first 2 phases of the process. So how it is that we develop those research questions and we gather that evidence. I will very briefly touch on the other phases of the process, so 3, 4, and 5, but we won't go into those in depth at this point. Right now, we're really going to focus on stages, or phases rather, 1 and 2. So just to begin by developing the questions. So as Dr. Chang mentioned, we do this in a PICO format. And so PICO is an acronym. The P stands for a patient, a population, or a problem. The I is the intervention of interest. The C is the comparator, although sometimes the comparator may be a placebo or treatment as usual. And then the O is the, or R, the outcomes of interest. And we use this framework to ensure that the questions that we're asking are sufficiently focused so that they are actually answerable questions. Because one of the potential challenges with a clinical practice guideline is that we may begin with questions like this. So we could begin with a question like, in symptomatic patients with ONFH without femoral head fracture or collapse, is THA beneficial? And so if we were going to put that into a PICO format, we could tell that the patient of interest are symptomatic patients with ONFH without fracture or collapse. We would know that the intervention of interest was THA. The comparator presumably is no THA. But then we have this question of what it means to be most beneficial. So oftentimes when we begin a clinical practice guideline process, the questions that people may have would be, what treatment is the best? What diagnostic test is the best? And it is important to think through how it is we are defining what it means to be the best in a particular question or context. Because with outcomes, there are, of course, desirable outcomes and there are undesirable outcomes. And so in this particular question, maybe we would say that a desirable outcome would be improved quality of life or radiographic improvement. We might have undesirable outcomes like postoperative complications, further surgery, increased costs of treatment. And it's fairly simple to say what is desirable and what is undesirable. Generally speaking, most people would agree that postoperative complications are undesirable and improved quality of life is desirable. The challenge becomes when we say, what are the most important? Because what is most important will depend on who the audience for the clinical practice guideline is. What may be most important to the patient might be the improved quality of life. It may be whether they as an individual will have postoperative complications. If we were asking a policy or a healthcare system and looking at it from that perspective, they perhaps would be more concerned with radiographic improvement or costs of treatment. This isn't to say that any of these outcomes are, better or worse, and that these different groups would not care about all of these things, but the outcomes that would be most important to them and would most accurately define what it is to be best or is to be beneficial would depend on who it is that would be the audience for that clinical practice guideline. And oftentimes there will be multiple outcomes that will be important. And so one of the steps that we take is to rank these and quantify them. And so generally speaking, this is done on a 9-point scale. And in this 9-point scale, we say that anything that is ranked sort of 1 to 3 is of low importance. Things that are ranked 4 to 6 are important, but they are not critical. Whereas things that are 7 through 9 are critical for decision making. And you can have multiple things at each level, so it's not that you always have 9 outcomes or that you must have at least 9 outcomes, but this is just a way that different individuals can say how it is they weight certain outcomes. And so we can determine what it is that is truly most important amidst all of the outcomes that we might be looking at for a particular question. So it helps to focus the question overall, and it helps to focus the process overall. So here you can see a refined version of that earlier question. So here, instead of saying if THA is going to be beneficial, we're defining that as improving quality of life. So that is the measure of beneficiality that we are considering here. And this is just some examples of outcomes that could be ranked in this order. So, in this hypothetical process that we're seeing here, or this this hypothetical scenario, perhaps pain was ranked as being the most important outcome, whereas function was considered critical, but perhaps not as critical as pain to the overall decision-making process. Maybe whereas revision surgery was an important consideration, but was not critical to decision-making. And I'm realizing now that unfortunately the Zoom bar that is, at least on my screen showing me the participants, is blocking the top of the slide deck. I'm not sure if that is also occurring for you. If it is, I'll just say that what is hidden under that is just an arrow and the word measures. And so we have these measures and these time points, and what this was meant to illustrate is simply that although we might have a single outcome, there are oftentimes going to be multiple ways to describe that outcome. So if we think of something like pain, or we think of something like function, there are many instruments that one might use to describe that. There are many possible proxies or surrogates that we might use to describe pain, and that might be measured at different points in time. We could also think of an outcome like fractures, for example, and it is possible that there may not be data on rates of fracture, but perhaps there would be information on bone mineral density, for example, which is all simply to say that when we talk about these topics and even our critical and our important outcomes, although they may be our critical and important outcomes and they are central, sometimes we do need to look at proxies for those outcomes and consider the heterogeneity and the differences between the different instruments and the different measures that may be available to us. So there can, even if we choose a small number of outcomes, there can still be a number of different data points to consider that relate to those different outcomes. So here is just kind of the most refined version of that question. And again, there'd be many ways to perhaps define these outcomes. This was just the example I was using here, in which we've gone from describing our outcome as just being most beneficial to instead saying that we were looking at improvement of quality of life. And now we've defined that to say that we are looking at the improvement of quality of life as defined as pain and function. And it is helpful to be as specific as possible or as reasonable in defining these outcomes, again, to allow for sufficient focus so that it is possible to address questions in as concrete a manner as one can. So once you go through that process of defining these questions and determining these outcomes, the next stage is to gather the evidence together. And some of you may have done systematic reviews or meta-analyses previously. I'm sure you've all read these sorts of works. And so some of this may be familiar to you, but I do want to describe the approach that is considered best practice, generally speaking, at this point in time in clinical practice guideline development. So if you are familiar with systematic reviews, the flowchart that you're seeing on the right of the screen probably looks fairly familiar to you. This is what is known as a PRISMA flowchart, and it describes the process through which one arrives at the evidence and the body of evidence that relates to a particular PICO question. And so usually when we are at the top of the flowchart, that is when we are beginning the process. And that is where we are attempting to gather the world's literature on a particular topic. And so this is where there is a lot of intensive and comprehensive searching of the literature that's being done. There are best practices that guide how it is searches are developed and executed. And I am happy to talk about that. Yeah, and we will have time for questions at the end. Just for the sake of time, I'm going to just move through this, but please do feel free to put your questions into the chat box, and we will have time at the end of the session to address those. So sorry, I should have mentioned that earlier. Of course, if you have something urgent, please do chat it to either Carol or Dr. Cheng if there's something that you need to have addressed at this moment in time, and we will make sure to do so. So generally, in the literature searching process, we're going to search between 7 and 15 databases, depending on the topic. And our goal is to create a balance between sensitivity and specificity. So we want to find everything that has ever been published on a topic, but of course that does not mean that we want to look through 2 or 3 million articles. That would simply not be reasonable, to say the very least. So I do want to show you some of the tools that we're going to be using for this. Now we do have some videos embedded in the slides, but I'm also going to go live in a minute. Before I do that, just if this happens to be of interest to you, I did want to share one of the searches that was developed in one of the databases to help address this question. So this is the search algorithm for the search to do with ARCO stage 1 and 2 without collapse. This is just for one of the databases. So each of the PICO questions has its own search strategy associated with it. And so the balance is, or the intention is again to create that balance between what we call in information science precision and recall, which is generally sensitivity and specificity. And so these searches have all been developed. Dr. Cheng and I have worked on them over the past few months to refine them so that we do have that balance between sensitivity and specificity. This is the search in one database. So this is in Medline through the Ovid interface, but it has also been implemented across other databases, and those results have been compiled.
Kayla may make a comment.
Yes, of course.
Just for the group to know that the American Academy of Orthopedic Surgery's research arm did also receive these same questions and do a literature search and came up with a similar number of articles. So I think it verifies the integrity of the search process that we've undertaken.
Oh, wonderful. Okay, so I am going to hopefully, can you all still see my screen? I very much hope you can, otherwise this may get a little bit tricky. Okay, I'm not hearing anybody say they can't see anything. So what I wanted to kind of speak to quickly is that we will be using a number of tools to help facilitate this process. One of them is going to be called Rayon. And so after today's session, you will be receiving an email invitation to join a project in Rayon, and that email will look like this. The subject line will be, "You have been invited," and it will come from Rayon, QCRI. And this is a tool that will help us screen this body of literature that we've been working with. So when you receive this email, it will just let you know that you have been invited to collaborate on the following systematic review. If you already have a Rayon account, if this is a tool that you have used before, you can use this Access the Review button right here. If you have not used Rayon before, it's very easy to set up an account. So you would just go over here to where it says, "Please click here to do so." You confirm your account. All you need to do is just establish a password. So you can choose whatever password you'd like. And it will ask you to enter some information about yourself. So it will ask you to enter your first name, your surname or your family name, your institution, and I believe that is essentially it. So it does not ask you for a lot of information. And then you will be given immediate access to that account. So as I said, you should be receiving this invitation within the next 24 hours. If you do not, please let either myself or Dr. Cheng know, and we will make sure that you have access to the resources. I should also mention there is a tip sheet for using Rayon as well, which will go into some of the details of how to access Rayon as well as how to use Rayon effectively. But we are going to go through some of those pieces here today as well. So once you have accessed Rayon, you will begin on the screening process. And that is really once we begin to work with the literature. So it's where we move from gathering the literature into actually screening it. And it is going to involve using inclusion and exclusion criteria that are defined prior to the screening process. And we're going to discuss those a little bit more. So each of the items within the project needs to be screened by 2 independent reviewers. So 2 researchers both look at the item and determine whether or not they feel that it is relevant to the question at hand, whether it meets those criteria. Okay. So once you actually are using Rayon, so I should mention that you can either access Rayon by going back to this email and clicking access the review, or you can go into the URL directly, which is rayon.qcri.org, whichever you'd prefer. And I'm just going to pull this down for a second so that you can see, or I can see rather clearly. So please ignore the long list I have here. You will not have, these are all my personal reviews, so you won't see this big list. What you will see is there are a number of different tabs over the top, or at the top rather. And so for you, the projects will all be listed under collaboration reviews. And so the projects that we're working on are right here. We have 3 of them to match with the 3 PICO questions. And so I'm going to, perhaps if I've been assigned to this ONFH ARCO Stage 1, if I want to look at the review itself, I just need to click on that topic. And I can see how much of the work has already been done. So I can see that there are 51 articles that are being excluded, and there are 47 articles that are being included at this point. If I want to do some screening myself, what I do is just click on this show button right here. And this brings me into the Rayon project itself. And so there are 3 panels within Rayon. There is this citation list right up here. There are these filters over on the side here. And then when I click on any of these items, the information regarding that particular item will pop up in this bottom panel right here. And so I can see the citation information as well as the complete abstract. And it will give me sometimes a little bit more information down here. I did want to point out 2 filters that it is important to set. Again, all of this information is available to you in the Rayon tip sheet that's being sent out, but it is very important to set these 2. So under inclusions decisions, we just want to set this to undecided. So this limits my result set to only those items that I have not yet voted on. So I have already excluded one item. When I click on undecided, I am no longer going to see that item. So it shows me only the work that I could still do. And then under this box right here where it says maximum collaborator decisions, I just want to select at most one. And so what that means is that I am going to look only at things that have not yet been screened by 2 individuals. So if they've been screened by 2 people, nobody else needs to screen them. And so by setting these 2 filters, I am looking only at the work that still needs to be done on the project, as opposed to everything that could potentially be done.
Caitlin, one comment here.
Yes, of
Just want
course.
to clarify that our goal for this process in the literature review is to have every article screened by 2 people. So that's why the settings are as they are. When there's a conflict, we'll go into the resolution process a little later. But the goal is to have every article screened by 2 people for either inclusion or exclusion in the articles that'll subsequently be analyzed at a deeper level for their data.
Yes, yeah, exactly. So that's why it's really helpful to use this maximum collaborator decisions, because then you're seeing only things that will be screened by, or that still need at least 1 screener. So you don't have items that have already been screened twice that potentially are being screened 3 or 4 or 5 times, because that would be unnecessary work that somebody may be doing. To actually screen articles, you're going to be using these 2 buttons down here. So it would be either to include if you feel that an article is relevant to a topic, or you would exclude if you feel that the article is not relevant to the topic. And I'm not going to click on either of these right now, but if I were to click, it would remove this from my list because it would no longer be undecided, and I would just go on to the next item in the list. Now, I did briefly want to touch on what it means when we talk about inclusion or exclusion criteria. And the inclusion or exclusion criteria are really just what it is about those articles that would make them relevant or irrelevant. And that may be to do with the population that the study describes. For example, it may be a pediatric population versus an adult population. There may be comorbidities that would make certain groups less relevant to help address a question. There could also be characteristics of the study, for example. So sometimes people may restrict if a study is randomized or observational. People may eliminate things like single case reports, or they may eliminate items that don't include at least a minimum number of patients. So perhaps excluding all articles that do not include perhaps at least 10 patients as a minimum. Or there may be restrictions around the duration of the study. So a follow-up period, for example. So saying that, there must be at least a minimum 6-week follow-up period in order for a study to be included. And there's no standard set of inclusion or exclusion criteria. Much like the outcomes, these are developed for each project to ensure that the items that are ultimately being included are going to be those that help to address the questions and help to form those recommendations. Okay, and so now we're going to go into our last demonstration of Rayon, and again, all of the things that I'm describing are going to be available to you in that tip sheet as well as in the videos that are embedded. And this is going to be, this will be in a little bit of a later stage. So this is where we move into the full text screening of the project. And so we're not quite there yet with your project in particular, but I did just want to show you that functionality. So this is another project, and essentially what I just want to point out here, so we can see that there are PDFs attached. So one thing to be aware of in the Rayon system is that when we move to this phase, we can attach PDFs of articles to the citation list. So nobody needs to worry about finding certain articles or anything like that. And the PDFs will just open up in the system themselves. So you can just review them that way. And in this case, the big change here is just that I'm listing a reason for excluding this study. So this was a review article, and so I excluded, and then I just listed a reason, and in this case it was that it was the wrong study design. So here we're just using this drop-down list, and we might say that something is the wrong population, the wrong outcome, just to justify why it is that that potentially relevant item is not being included in the study overall. But the functionality here works the same way as it would in if there were not PDFs attached. It's just now this is showing you how you have access to the PDFs within the system itself, and the assignment of reasons for exclusion at this point. Because this is where we've moved on to this second stage of the gathering evidence sort of process. So we've screened the titles and the abstracts of those records to see whether or not they look relevant based on the inclusion and the exclusion criteria, and now we're reviewing the full text of the article. So this may be that perhaps there was something that you simply couldn't tell based on the abstract alone, whether, for example, it had the outcomes of interest. And so you're looking at the full text to confirm that information. The big difference between this stage and the previous stage, aside from having access to the full text of the article, is just that need to record why it is that something is being excluded. And so that could be, as I said, due to wrong population, wrong intervention, whatever criteria are relevant to a particular topic. But the goal of this process is really to start out with a very broad body of literature. So oftentimes in these processes, people will look at hundreds, sometimes even thousands of titles and abstracts, and apply their inclusion-exclusion criteria to ultimately come up with oftentimes quite a small number of articles that are really focused on addressing the question at hand. Because once we have arrived at that point, that is really the data that one is going to be working with to answer those PICO questions and subsequently formulate the recommendations. So it really is that point in which you have the body of evidence that is relevant to that clinical practice guideline overall and will form the evidence basis of the clinical practice guideline. Now, of course, just because something gets published and is relevant does not necessarily mean that it's a perfect study. So it is important for us to consider the quality of the underlying studies and to assess the methodological quality of those studies. Now, as I said at the outset, I'm not going to go into these stages in much depth at this point because this is a little further on in the process, but we did feel it was important to touch on them to give you a sense of what the overall process looks like. So with methodological quality, oftentimes we are assessing for risk of bias within the underlying study. And so this may be, for example, in an observational study, there may be confounders that the researchers were not able to control for. In a randomized study, perhaps people became unblinded, or there was a bias in how people were randomized. Perhaps that randomization was not done effectively. And so it is important to account for those flaws that could potentially lead to concerns regarding the quality of the data. And now there are validated tools that can be used depending on study design. So just a few examples here. You can see on the screen, so Quadis for diagnostic accuracy, for example. And it's useful to use those validated tools because, well, they are validated instruments, but also because it helps to provide direction and consistency for how it is that the methodological quality of the studies are being determined, and then can subsequently be described in the recommendations. Because of course, if there are perhaps some significant limitations to the study, which may simply be inherent to the study design, it may not be any reflection upon the researchers. Nevertheless, it may also limit the conclusions that you would want to draw from those studies. So that is done at an individual item level, where for each study that is being included in this review, or in addressing a PICO question, the study or the quality of the study is being assessed. But of course, one of the key features is to bring these different articles together, these different items together, to say what it is that is known in the body of the literature. So we have to begin to synthesize that evidence. And so that's bringing together these assessments of these individual studies to look at what it is that is known about these certain topics. And that is considering the body of evidence overall for each outcome of interest. So looking at the methodological quality of the component studies, but also thinking back to the original PICO questions and to the original aims of the clinical practice guideline to see how closely that body of evidence is really reflecting what it is that the CPG was aiming to address. So how closely it actually answers those PICO questions that have been described, and how strong the evidence is that answers those PICO questions. Because from that synthesis and from that understanding of the body of literature, that's where we develop those recommendations. And that is where the group is going to review all of the evidence that's been gathered and to assess it based on what are called 4 decision domains, but it's really just 4 different areas of consideration. So we want to think about the quality of the evidence and the confidence that we have in that evidence. So if there are perhaps there are studies, but they have there are significant limitations. Perhaps the studies, there's some issues with the methodologies of those studies. We may be less confident in the quality of that evidence. We want to consider the balance between desirable and undesirable outcomes. So perhaps if there are significant undesirable outcomes, that may potentially outweigh desirable outcomes. So it's important to keep or sort of weigh those 2 equally. We want to think about the values and the preferences of the group that the clinical practice guideline is addressing. So how closely would that recommendation actually help to reflect or be positioned in the context of those values and those preferences? And then we want to think about the resources that are required. If something is a recommendation, so say a certain diagnostic test or a certain intervention, but the equipment necessary is very rare, or the cost is very, very high, it's a very expensive procedure, a very expensive piece of equipment, that may reflect in the recommendation that's being made. And so ultimately, the way one draws conclusions is to look at the evidence, look at its methodological quality, and then put it in the context of the PICO question and the audience that we've defined in defining those outcomes. So just as a recap, because I feel like there has been a lot of information here. So as I mentioned at the outset, there are 5 phases of the CPG process. And so today is when we're going through developing the question and gathering the evidence. And then we'll subsequently move on to assessing methodological quality, as well as synthesizing the evidence and developing recommendations. And there's some proposed timelines here, which of course you are welcome to comment on, and we'll have some time for discussion of those a little bit later. And I do just want to emphasize that there will be support throughout. So we will have additional instructions to follow, and there will be additional opportunities for discussion of these areas. I also want to provide, so as I said, there are videos, there's a tip sheet, but I also wanted to put on this slide deck your steps for accessing Rayon. So as I said, you will all receive an email invitation, and you just want to click on that confirm account link, and then you just establish your account by entering the password. There will be 3 different projects that are set up. You will be invited to the project that is relevant for you. So the group that you have been assigned to, and that will be available to you under the Collaborative Reviews tab. And then just click on Show to actually access the project, and you can just set your filters. So inclusion decisions undecided, maximum collaborator decisions at most 1. And then when you click on any item in the citation list, you can either mark include or exclude based on the inclusion and exclusion criteria. And with that note, I am going to pass things back to Dr. Cheng, who is going to speak to the proposed literature screening criteria. So those inclusion exclusion criteria.
Okay, thank you very much, Caitlin, for reviewing outlining the clinical practice guideline process of the 5 different phases that we'll be following. The goal of this call was to start at a very basic level and make sure that we all are at the same knowledge base, whereby we're going to begin the literature screening process. So let's move to the next slide, please. The process has been described by you. While we're going to the next slide, I just want to let you know that we will have a project web page that we'll send to you, since a number of these files will probably get lost in your email inbox. I know it's difficult to organize for me, and so to make it easier for you, some of these tip sheets and the presentation here and so forth, we'll have these organized in a place, central site on a web page that you can access and download, so you only have to keep track of one site. So for the first question, the PICO question has to do with patients undergoing diagnostic evaluation. What are the studies that are most sensitive and specific for the determinants listed there, A through D? Let me ask you, Caitlin, I noticed that some of the PICO questions perhaps should be rewritten. At some point, do you advise that we rewrite these in maybe a even better PICO format than was drafted at this state?
I think that's certainly a possibility. I think the PICO questions as they are, I think it depends on how the group is feeling about them, if there's a shared understanding of what those outcomes are. So you could redraft the PICO questions if you feel like that would make it easier to operationalize them.
I think most of us understand what the question's addressing. It's just a matter of, I suppose, leading to the search, but since the search has been done, it maybe doesn't matter at this point. That, I guess, would be my thought on the matter. Okay, so inclusion and exclusion criteria. When you are reviewing whether or not to include or exclude an article in the screening process, it's important for this question to focus, to be sure that the focus of the article is on imaging and it's not on treatment or an outcome or some other aspect of the osteonecrosis disease. So really, we want the focus of the article to be on imaging. The second criteria would be that we're only going to be looking at studies that report on imaging in humans. We will not look at articles that look at animal studies. So that's pretty obvious. Third might be we should exclude articles that don't represent original data. This would be editorials and reviews in particular. Case reports is next that we would also exclude, since these don't provide levels of evidence that would be appropriate. And then we will be concentrating on the adult population. We will not be concentrating on Perthes or on osteonecrosis in adolescents or younger, although we know this disease does occur rarely there in some situations, like with the leukemia population. We are going to focus primarily on those who are skeletally mature or above 16, because that's a more uniform patient group. Okay, so the next question.
Ed,
yes.
you're saying exclude single case reports. How about a series of 5 patients or 10 patients or 15? Is there a number there that can be a little bit more quantitative?
Right, Michael. So a case report would be 1 patient. If there was an imaging article just on one unique aspect of a case, I'm not sure that would qualify. We like to say that 2 patients is case after case, and 3 cases is in my series. So I think we don't, as a group, have a decision on that. I guess my personal opinion would be that if the case report was of 1 case, then that's probably not of much use. But if it's a series of cases, that's probably going to be somewhere in 3, 4, 5 or more cases. We probably wouldn't classify that as a case report, despite how it might appear in the Medline. I think that's probably a little bit higher level of data since it's occurred in multiple patients. But I'm certainly open to many other opinions on that. Does anyone else have a comment, or would be your view on that?
Yeah, I would like to make a comment. I think that's a good question, Michael talking about. I would say at least 3 cases above. Otherwise, even the RRBs will not consider this a study if below 3 cases. So that's the I think I don't wanted to say that's the final answer, but I want to hear it from everybody. And also many, the other thing that follow-ups, most of the journals will say, 2 years follow-up, the good journals. Do we want to say something, the follow-up period? And also some good journals also define the level of evidence. That'll be easier for us to say if we see the level of evidence when we review the journal, and how we're going to include that part.
Yes, Trey, those are very good points, and they pertain mostly to the second and third question, and you'll see that in just a moment. I think, how do people feel about the case report being at least 3 or more would be classified as inclusion, and something that was only 1 or 2 cases would be excluded?
So I think that depends on whether you are answering PICO number 1, 2, or 3. Number 1, when you are specifically looking at diagnosis, and if you only had 3 and you have most sensitive and specific, there's no way you can determine sensitivity or specificity with 3. My other comment has to do with monitoring the effect of any intervention. How can you do that if you have excluded articles that are not articles that have treatment, because treatment and intervention are the same thing?
So it's just the focus of the article, Lynn. It's not referring to necessarily the inclusion of patients who are treated. Of course, you have to treat patients to monitor the effect of that. But I think it would be that the thrust of the article is dealing with imaging and how you might monitor treatment.
So how could you determine sensitivity and specificity?
Well, those are statistical terms, of course. I think here we're referring to it in a qualitative manner in terms of which, in terms of the principle. I don't think that we'd be able to actually statistically calculate the sensitivity and specificity in those terms because we won't have, numerators and denominators necessarily. So I don't think this would be a series where we're abstracting actual data from papers to measure that. I think when the question was written, it was written with the intention that this was referring to the principle of the matter.
I understand that, but I'm saying if you are accepting a series of 3, how does that tell you anything about sensitivity and specificity, which is your question to be answered?
Well, again, I think your point's well taken. You cannot do that, obviously, from a statistical standpoint. But I think when the question was written, we could have just said, what imaging studies are most useful? But that's not a very specific PICO question. So I mean, when it comes down to it, I think you're correct, Lynn, that if you really wanted to measure it, you would have to have articles of a much larger number of case count. But when we want to know what imaging studies are useful for the evaluation of diagnosis or evaluation of treatment effect, we're going to have to rely upon something more than just a case report. But if there's 10 patients, even with 10 patients, you probably can't calculate sensitivity and specificity with any accuracy. But certainly there's value in the data that's there. So I think this is how we're trying to thread the needle. In the sake of time, I think we should move on here to the second question. With the second question, the screening criteria, the second question deals with patients with early stage disease. And the third question, as you know, deals with patients with late stage disease and the treatment of both of those situations. So given that they're somewhat similar, we felt that the inclusion and exclusion criteria could be pretty much the same for both. Let me just leave that open for discussion there. Any comments or feedback on that? Okay, so this will save some time for us if we can have the same inclusion and exclusion criteria for screening for both the second and the third question. So here, to the point that was made about evidence level, we felt that, the body of literature for this disease is, in terms of evidence levels, quite poor compared to other aspects of medical practice. So we felt that we should include all evidence levels, 1 through 4, and leave out the level 5. But we felt that we could not exclude it to only level 1 or 2 cases because that would severely limit the ability to evaluate the literature and probably leave out a number of papers that have important information but are not rigid enough or performed or written in a way that's rigid enough to qualify as a level 1 or level 2 study. Certainly there are very few randomized controlled trials in this disease. As we all know, there's only, we can count them on our hand. So there are just very few. And our guidelines would not be worthwhile or usable if we only limit it to level 1 or 2. So the case series, again, this question came up just a minute ago. We felt that should be, when we're evaluating treatment, it should be more than just a couple of patients. So arbitrarily was set at 15 patients. Certainly, I think that's open to discussion since there's no actual basis for setting 15, but it was felt that that was a reasonable number. Again, we're limiting to humans. We're looking at cohorts of patients from institutions, but we don't want to count patients twice or institutions twice. And so institutions that have been prolific and reported on their outcome with several different studies, we want to try and avoid duplicate papers. The methodology. So again, for level 1 or level 4 studies, it's going to be either prospective or retrospective. This will not be any kind of a review article that we would include. It would be the diagnosis, obviously limited to non-traumatic osteonecrosis. We're not including traumatic osteonecrosis. And again, skeletally mature, age over 16. We would include papers that obviously all papers will have imaging to assess for subchondral collapse, at least a radiograph. But we'd like to limit it to those that include at least something more than a radiograph. because the radiograph is, as we all know, not the best sensitivity for, does not have the best sensitivity for detecting a fracture. I mean, that's one of the questions we just posed a minute ago, but I think most of us who are experts in treatment get more than an X-ray in most cases. And then treatment intervention is uniform across the entire treatment cohort. The outcome includes a metric to look at radiographic progression and not only conversion to total hip replacement. And that's because if you want to look at the outcome of this intervention, conversion to total hip replacement is a very inexact outcome because there are all different levels of threshold for deciding to perform a total hip replacement as opposed to radiographic progression of disease, which is a much more clearly defined event and more timely. And then we felt to the point that was just raised about follow-up, the follow-up should be at least 2 years. Certainly, again, this is arbitrary and open for discussion. So let's hear any thoughts about other people have about these proposed criteria for screening the literature.
Hi, Ed. This is Rafael Sierra. Thank you very much for organizing this and including me. It's great to be here, and I hope to meet everybody in person at some point. I just have a quick question about the criteria. So do all of these have to be met in a study to be considered to be included? For example, if you have outcome but without advanced imaging, then that study is excluded, even if it's got 10-year follow-up, for example. Or number two, if a study only reports total conversion to total hip, but it does not have radiographic progression, is that study excluded as well?
Well, that is the way the criteria are written, Rafa. Let me ask what other people feel about that.
So Rafael, hi, thank you for joining the meeting. This is Trey. So I would say, you know, for stage 1, stage 2, it's just so many different treatment options. Just talking about conversion total hip, apparently is not enough. We definitely needed to include, you know, all those cases if they report, you know, progression to, you know, from like a stage 2 to stage 3, something like that. And, you know, we are currently doing a study that's also led by the ARCO board. Hopefully, we're going to identify enough, you know, evidence, basically, will provide enough evidence to see at what stage with CT scan, you know, as the diagnostic tool to see they're going to progress to the next, you know, level. That study is almost through, where we have the reliability results now. We just needed to associate it with the outcome. So we're at this stage now. Hopefully that will provide some data. But with this study, you know, doing a lot of literature review, we'll probably be able to provide some information on that, you know, in addition just to convert into total hip.
So, Michael, okay, comment.
I was just going to clarify where it talks about advanced imaging. This is in regards to the diagnosis. I'm not sure, most studies do not use advanced imaging to follow patients routinely afterwards, after the intervention. So I'm not sure if that was clear to everyone.
Oh yeah, that was not clear. I thought it was, you were talking about following patients, because that's.
Yeah, I agree with you. The advanced imaging is not meant or referring to the following or surveillance of patients after treatment. We can clarify that on this criteria. That's a good point.
So Michael Mont, yeah, thank you, Rafa and Trey, for bringing up some of the points. My view would be to be a little bit more inclusive on some of these criteria and let the individual groups decide which are good or, you know, poor methodology studies. For example, follow-up, there are studies that have follow-up and they range from 1 to 8 years. So what are you going to do? Eliminate that study, even though 80% of the patients are followed for over 2 years? There's a group under 2 years. And then what Rafa said was correct. So I think that, you know, I'm okay with the level, grading things by level of evidence, the beginning, the human, but I think let the groups decide the methodology and the quality of the studies, and don't be as restrictive, because I mean, Ed, you know what's out there in terms of the different papers. We don't want to be restrictive at the beginning. Let the groups decide what's worth including in when they finally come up with a recommendation. That
So
would be
Michael, do you think if we changed it to say mean follow-up of at least 2 years, would that be lenient enough, do you think? Or what's your thought on that?
I mean, I mean, you could be very strict, but I already know you couldn't say minimum follow-up 2 years. You'd be wiping out a lot of papers. Mean would be 2 years. Yeah, that would be okay. 2 years or more. You don't want these papers that report on wonderful results at 8 months. Sure, I agree with that.
Okay.
And I have another question. This might be more for Caitlin as well, but you know, each of these questions is divided really into 3 or 4 questions. And the papers, for example, on the right side of this slide, I mean, some of them may not even apply for example, to question C, for symptomatic patients should THA be performed to reduce pain. I mean, all these criteria that you have there, I mean, they're not going to be part of that paper other than prospective, retrospective, or no reviews. Otherwise, the criteria are not there. So should there be more, should each of these questions be only one specific question to address with certain specific criteria? Going back to question number 1, I mean, you have 4 different questions again in that same question, which is, 1 is the, you know, how do you screen, you know, how do you diagnose it? Number 2 is how do you follow patients? Number 3, I mean, all these studies, I mean, how are we going to screen for all these studies trying to answer one question that is really 4 questions? I don't know if that came through, but it's
Yes, Rafa, I understand that. So I think the literature screening criteria are not meant to be as rigid as maybe people are thinking. You know, I did this for the first 100 papers or so myself to go through the exercise, and you realize you have to have some criteria in your head upon which to include or exclude a paper. And if you don't apply them somewhat uniformly, it's just too haphazard. So they're meant to provide some guidance. I think you'll have to use your judgment sometimes as to when maybe to bend the rule. And also, it's not a list. So you're right that they are separate questions. PICO number 2 is actually 3 different questions, of course. But it's not as if the question has to check off every single inclusion criteria either. It's, I think, meant to be a yardstick, if I could use that term, for guiding you as to whether or not the article is important or not. Now, remember, it's not just your opinion that's going to make the case. Someone else is going to also review the article, and to the extent that you all agree, we will use or not use the article. When there's disagreement, we're going to ask people to iron that out, either by communicating with each other, or there will be an arbitrator, which will probably be the lead of the committee, that will have to come in as a 3rd vote to decide whether or not to include it or exclude it. So I think we have a fair amount of diligence in looking at articles. And I guess I wouldn't look at this as being so rigid that if the follow-up was, say, 23 months on 100 patients, well, that's probably some valuable data there. Because it didn't reach 24 months, I might still include the article. So I think we will have to use a little bit of our judgment.
So Ed, Michael Montagan,
Mm-hmm.
This methodology, I agree with you, should be really straightforward and easy. Somebody gets an article, just go through all this stuff, and it should take no time to grade the article and say, this is we're going to use this article or not. But maybe, Caitlin, you can answer this. On the later evaluation of a full article, when you're actually going through the article for bias, that gets pretty complicated. And, you know, if you don't have a methodology to grade an article for bias and all the specifics, that can take 15 or 20 minutes an article. So my question to you, Caitlin, Could you generate a checklist that everybody in this group goes through that says, okay, here's an article, check it for this. Does it have any commercial sponsorship? If it's a clinic, I mean, can you get that so that everybody uses this same checklist for each article and they don't have to spend forever grading an article?
Yeah, so that's actually our goal, is that we would be using essentially a checklist format where there would be some very targeted questions that people would essentially be able to respond yes, no, unsure. So there'd be a range of options that they could use. So rather than an individual attempting to appraise the article, they do have that guidance. At this stage with the literature screening, the goal is to really, most of the time, to screen a title or an abstract takes between 30 and 60 seconds. So the idea behind the inclusion-exclusion criteria is really to make them something that can be very quickly, easily applied, so that you can look at that item and say, oh, this is a pediatric population, so I'm not going to include it. Or, this is clearly an editorial, so I'm not going to include it. But you are absolutely right that doing the methodological quality appraisal and doing the risk of bias assessment can be more time consuming. So yes, we would be using checklists, so that would be consistently applied.
Right, great.
And more streamlined.
Great, super.
Kaylin, in your process, you described reviewing the titles and abstracts and also the full text. Just to clarify, we're doing one screening here, correct? We're not doing two screenings. I mean, each article is reviewed by two people, but we're not all going to go through the articles twice.
Well, you go through the titles and the abstracts once with two people, and then it moves on to the full text screening phase. So there is that double screening as part of the workflow, but you're working in the double screening with the full text review. It's really more confirmatory that those titles and abstracts that you had earmarked as being relevant are in fact relevant overall. So it's confirmation of relevance.
Okay, so you're going to ask everyone to go through the title and abstract and include or exclude it, and then resolve differences, and then we'll have to go back and do a full text review? Is that what you're saying?
Yes.
Yes.
Boy, that's quite a bit of work.
That's the guideline.
Yeah, I mean, that's what makes it such strong evidence, is that somebody has done this sort of work. But that's, again, why you want to have these inclusion-exclusion criteria that you can essentially, by the time you're doing that full text review, you're working with a fairly small body of literature, because it can be very time-consuming if you have, a very large body of literature to review at that stage. So that's why I usually tell people, particularly in the title abstract screening phase, you want to be, for lack of a better term, ruthlessly efficient. You're trying to get rid of all of those items that are not going to be relevant to addressing the overall question, because they ultimately won't add a lot of value, but they could add a lot of time and a lot of energy to the process.
Then that makes the case for being very strict with the criteria then, because that criteria is what we're going to use to then decide the full article review.
You mean strict when you're looking at the title and the abstract, correct?
Correct, yeah, so strict with that. So if we are going to decide that we're not going to include patients or studies that don't have both radiographic progression and conversion to total hip, well, that will take out a bunch of papers that only have progression to total hip. If our question is both decreasing progression and decreasing conversion to total hip, for example, based on the treatment that was done, so that we have to be very strict and not say, well, maybe 23 months or maybe 24. If it's 2 years, it's 2 years.
Other thoughts on that matter? Those are good points, Rafa.
I agree. Well, if you look at this question on the screen, pickle number 2, if you take the evidence level to 1, 2, 3, and then you will eliminate the criteria number 2, so case series. So that way will significantly decrease your article volume. I would suggest that, we'll say the preliminary results and see how many articles there. And then you can change the your criteria at that time based on the group decision, like Michael suggested. You know, we can always see how much work we have to do, right? If the load is too much, and then we have to change the criteria.
Yeah, yeah, Trey, I don't agree with that. When you develop guidelines, you start at the beginning exactly the way Ed is doing it. He's doing a great job. You put down these criteria, and you can't change it midstream, like what you're suggesting. And if there's a lot of articles, that's why we have a lot of people. We divvy out the articles, and I mean, I don't know if you've been on any of these guidelines. You just split up the articles, and everybody does their share, and they grade them. And now you have two people grading them, and that's how you come up with that best practice guideline. So
Yes.
I would, you have to
agree with you, Michael. It's just like, you know, depending on the next step, how many full text article we have to go through, how many data we have to retract from there.
Okay, so
Yeah, I completely agree with what Michael just said, Mike. But again, if we set the criteria ahead of time, then we're probably going to only screen through the best papers that will give us the best data to support our questions. If we include too many papers, even level 4 that only have very short follow-up, et cetera, we'll get a large number of papers that we'll all have to review. So if we set these criteria ahead of time, then we know that we're reviewing less papers, but they will be probably the best papers out there in the literature that will support our questions.
So how about this so Rafa, great comment. So how about this? If there are enough level 1, level 2 papers, then, or even level 1, 2, 3, then we don't have to go to level 4, just get rid of those. If you have a topic that doesn't have enough level 1 or 2, which there are some, then you have to go down to level 4 because you're going to get very few papers to review. So we could agree if we all want to agree ahead of time to something like that, as long as we agree to whatever the rules are ahead of time. And maybe you need another little meeting to agree to it. But I'm into what Rafa said. Let's not use level 3, 4 if there are many papers. But there are some topics you have no choice. You have to use level 3, 4.
So I think one way around this, you all have good points, is that there's 2 screenings, remember, going on that Caitlin specified. So in the first one, that's probably going to be a little bit less rigid, and you'll see what you come up with in that first screening. And then that second screening, you can decide how rigid you want to be in applying it. Again, it is going to be reviewed by several people. It's not just your decision. So don't be too concerned that you're the only one making this decision, that there's another person looking at it too. But I think for the sake of inclusion, Michael, you're concerned about that. We'd probably be slightly less rigid on the first screening with the title and abstract. And then when you go into it deeper in the full text, you're going to be more rigid about, and you also have a better idea of how many papers are actually there now. And you can be more rigid in the application of that. Now, this is going to depend a little bit on the group lead too, but that's how I would envision this going forward. All right, in the sake of time, I don't want to continue discussions a lot longer. Why don't we go to the next slide? I think we need to just come to the next steps and what we're going to perform. At this point, we'll start the process. Remember, there are probably, if you didn't see the search, there's probably some of the articles have 600 papers or 590 or 600 papers to review. If you do the numbers, it comes out to, if there's 8 to 10 people on the committee, everyone's going to have to review about 150 to 200 articles. And so the Rayon, the beauty of the Rayon software is everyone can work at their own time pace. The Rayon will only present to you articles that have not yet been screened by other people. So the work can be done asynchronously. It does not have to be done as a group or in person. I mean, we were hoping to do some of this at the workshop, but obviously we're not having the workshop in person. So you can work at your own pace. We'll set a deadline. The group chairs will be able to watch the process on Rayon. and see how many, and you'll also be able to determine how many articles you have rated. So if you only have 10 minutes here or there, you take 10 minutes. It takes about, once you get started, it's about a minute an article. Sometimes it's faster than that, and for some articles it takes a little bit more time. But the initial title and abstract screening goes pretty quickly once you get up started and see how it goes. The first probably 20 are going to take a little bit more time. I just want to hear some thoughts about how this process worked with the conference calls, and is this acceptable moving forward in this manner, since we're going to have to work together somehow across multiple time zones. Some feedback about that?
I think it worked
Well,
great.
don't want to say anything. This is really nice. I think it's very actually effective.
Any downsides, or anyone want to change it in any way? Okay, so I think I'll ask that the chairs or the leads for each one of those PICO question groups utilize a conference call and set that up when necessary. It may require a couple to iron out some issues. They can be hard to set up, but Carol can provide us with assistance in that regard. Okay, just before we wrap up, a couple of things for housekeeping. Number one, we do have a biannual meeting I want everyone to be aware of. That's going to take place in Seoul. The date is going to be pending approval of the board. It'll be the 2021 biannual meeting, and our colleagues in Seoul will be arranging that meeting, so you'll receive further notice about that. The second is I want to thank Carol Skaja in particular, along with Caitlin, for the work they've done to make this happen today. As you know, nothing happens in a vacuum, and it always takes many people, so I want to point that out and thank them in particular. And then you'll see the assignments to remind you. There are assignments for the group. You will receive that email, and then go ahead and start applying that criteria and start on RAN. Now, you're going to undoubtedly run into problems. If you run into problems, please contact Caitlin. She has an email listed there, or you can ask me. If there are technical problems with conference calls or whatnot, then speak to Carol Skaja or send her a note. She'll be able to help you with that as well. It looks like the platform worked pretty well today. It'll be recorded for review later on. Some of you may elect to have other individuals. The process of the first phase for literature screening doesn't take a high level of knowledge, actually. And so if you delegate this to some trainees, I understand some people may do that. I think further down the road, the other additional phases are going to be much more difficult and require higher level input and time commitment. So with that said, any other comments before I adjourn the meeting? Any comments from our colleagues in Asia?
Yes.
Has everyone fallen asleep?
No, thank you very much, Ed, Caroline. This is great. Really appreciate it. I think it's going to be very effective. It's going to be a successful project for ARCO.
Ed, can you tell me, is there a specific deadline that you have set for the first phase?
Well, so I didn't want to arbitrarily set that. Maybe we can do that on the call before we adjourn. What do you think should be the deadline? How long will it take to accomplish 2 screenings like this that Caitlin's asking?
It's hard to know about the second screening until we've done the first. I was just suggesting that we do something set a deadline for the first screening.
Okay, I'm open to suggestion.
My schedule is completely different than everybody else in the group, so I defer to them.
Well, okay, to start the discussion, I would say that at this point in time with the coronavirus pandemic, many of us have a little bit more time on our hands, ironically. So I would say we try and get the first screening done very quickly, probably within the month. I would think that that's a doable thing, and then we'll see how that goes before setting the second deadline. How do people feel about that?
So a month for you might work, but for those of us who have grants due, you know, and that's why I'm saying it's a different world. for me.
Okay.
1 month may be difficult.
All right. Well, what other people think? What would you like to do? I mean, be mindful, Lynn, the group that you're assigned to, the diagnostic question is a little bit easier than the other two. It's fewer articles.
Yes, I saw that.
Yeah. But any other thoughts? So is 1 month doable?
Ben looks like he has he's muted.
Ben,
But
did
he's
you want to
talking.
say something? Ben, if you're trying to say something, we cannot hear you.
Ben, we cannot hear you.
Yeah, Ben just put in the chat, he's saying maybe May 11th.
Oh.
Can you guys hear me now?
Yes.
Sorry about that. Yeah, May 11th would give a little bit of cushion, with Lynn having concerns on grant deadlines. That'd give us a little bit over a month, closer to a month and a half. Or do you want to do a little bit sooner than that?
I'm open to whatever the group thinks. I think, how does that timetable of May 11 look for our colleagues in China and Korea and Japan? Would that work?
I'm seeing a couple of people in the chat saying that May 11th would be fine for them.
Yeah, the Dr. Cruz, they're okay from Korea.
Yeah, we see your comment there. Okay. All right, Lynn, how's that work for you? May 11th then?
Okay, I'll
All
do my
right.
best.
We'll make May 11th a magical day to get that first screening done. I think we'll be all much more experienced at that point in time. And we'll send out an update as to what's happening at that point in time. All right, so everyone stay tuned.
In the future, Michael Mont, is there a way on these calls for you, Ed, first of all, Ed, great meeting, and really thank you, and Caitlin and everybody for doing all this. Is there a way on these calls to get a group vote? Like you ask a question and get the participants to say yes, no, or something like that. That would be like, that would have been very helpful here.
Yes.
Yes.
There probably is. I don't know myself. We
Yes.
can explore that.
There is a way to poll.
Oh, so Carol knows how to do that. So we'll have her send out instructions. We don't need to, I don't think we need to pull anything right now, but we'll look into that. Michael, that's a good point. Thank you. All right, with that said, stay tuned for further information as time goes on here. And I want to thank everyone for their time, whether it's early in the morning or late at night for you. I'm sorry that's the way it is, but I can't change that. That's the way the world is. And for the rest of you, please be sure and stay healthy and wash your hands and wear those masks. So thanks very much, everyone. And we'll adjourn the meeting at this time. Take care.
Thank you.
Thanks, everyone.